Today's topic given to me for next 25 minutes is changing landscape of anemia management, trying to find a fight between erythropoietin versus HIF-PHI. From this end to that end, whether we are able to cover a little bit about a basic understanding of anemia and CKD, few slides, mainly focusing on erythropoietins versus HIF-PHI inhibitors, desidostat, as Sir said, we'll be focusing on that drug which is available with us and the trials related to it, whether monotherapy is enough or whether dual therapy is required, whether there is anything based on that, that also we'll look into, and we'll end up with take-home messages. So as we start with basics of anemia, we are very much sure that any erythropoiesis requires erythropoietin as well as iron from pluripotent stem cells to pro-erythroblast via stimulation of erythropoietin, and thereafter the incorporation of iron to end up with RBCs. And we are very well aware that the chronic kidney disease, because of the inflammatory state, there is an increase in EPO resistance, increase in the hepcidin levels, which causes decrease in the iron absorption, mobilization of iron stores are decreased, there's decreased RBC survival. And adding to that, you've got iron deficiency, blood loss, and bone marrow suppression because of uremic toxins, which finally lead to anemia. And we are also aware that there are some easily correctable, potentially correctable, and impossible to correct causes where we just to know a few of absolute iron deficiency, B12 deficiency, hypothyroidism, which are easily correctable. And if at all to look into infections, hemodialysis, bleeding, hyperparathyroidism, pure red cell aplasia, malignancy for some of the potentially correctable causes. But as we move forward, the evolution of anemia in CKD, the management initially in the 1950s, we were talking about blood transfusions. As on we moved on, there was also an introduction of high molecular weight iron dextrans IV preparations, which had so much of side effects and hypersensitivity reactions. We headed towards 1989, where erythropoietins came and approved, and the use of EPO started. And the first generation to second generation darbepoietins. And as the time went on, we had a better iron formulation in the form of ferric carboxymaltose and isomaltoside with less reactions and rapid infusions. And then we ended up with now recent onset HIF, hypoxia inducible factor, PHI inhibitors, prolyl hydroxylase inhibitors, which as roxadustat, as and the other four which added to the ones vadadustat, molidustat, anorodustat, and daprodustat. But what is available with us at our this thing is our desidustat. So as we move on, we also understood in the clinical trials like normal HCT, COIR trial, where it was shown that the hemoglobin targets around 11.5 to 12 was good enough then, rather than achieving very high targets, which used to cause increased risk of thrombosis, cardiovascular as well as cerebrovascular stroke-like incidents. And in the following subsequent create entry trial as well, proving to the point. So with this, we came to a point of erythropoietin stimulating agents, where we knew that erythropoietin, which is basically produced 90% from the interstitial fibroblast of the kidney, in terms of response to hypoxia and anemia, it is mainly the outer cortex which can increase the expansion to production, and 10% of the things come from the pre-sinusoidal cells of the liver. So mainly in the fetal and perinatal period, it's the liver which predominates, and when in adulthood, it is the renal production which predominates. Then we introduced the recombinant erythropoietin, which is a genetically modified protein similar to the nascent EPO, with a backbone of 165 amino acids, as well as some glycosylated chains, which variations cause different forms of EPOs. And there was a set of different generations. First generation, which we had our epitoin alpha, and then we had epitoin beta. And in the second generation, we had darbepoietin with more better half-life, methoxypolyethylene glycol, and darbepoietin, as we know, is more stable, more potent. The elimination half of human single IV injection is up to 25.3 hours compared to our eptoin alpha of 8.5 hours. The subcutaneous half-life is approximately doubled, up to 24 to approximately 48 hours. And this helped in less frequent dosing. As far as ESA dosing was concerned, we were aware that it was based on weight of 50 international units per kg, 3 per week, with the frequency and maintenance for eptoin alpha being 1 to 3 per week, compared to darbepoietin, which was having a much longer half-life where we had 0.45 microgram per kg per week to 0.75 microgram per kg 1 in 2 weeks, and followed it by once a month maintenance dose, to something like continuous erythropoietin receptor activator like SERA, where we had the dose of 0.6 microgram per kg 1 into 2 weeks, and we continued the maintenance dose monthly with this. We are very much experienced with the use of erythropoietin over a period of so many years. And KDO had given its anemia guidelines, where it mentioned that all the correctable causes should be cleared before we initiate erythropoietin therapy, and then balance the potential benefits of reducing the blood transfusions or the risk of harm in individuals where the patients have any incidence of stroke, vascular access loss, or hypertension, where you have to cautiously use ESAs. Then the initiation KDO guidelines had mentioned that you have to look into all patients of CKD with active malignancy with a chance of anticipated outcome, whether there's a history of stroke, malignancy, and it should not be considered in patients of CKD not on dialysis with an hemoglobin concentration more than 10. We should avoid ESA therapy. It should be initiated when the concentration is less than 10 with the rate of fall of hemoglobin concentration, prior response to iron therapy, the risk of needing a transfusion if there's a risk related to ESA therapy. So it was basically individualized on patient-to-patient basis, and the presence and symptoms which were attributed to anemia. In pediatric population, it was more of a selection as per the individual patient with improvement of quality of life, the school attendance, performance, and avoidance of transfusion and potential harms. As well as in administration, it was in frequency was depending on the patient's tolerance, preference, and types. The EPO had a half-life of 6 hours IV administration compared to 24 hours when it comes to subcut administration. And the same terminal half-life of darbepoetin in adults with subcut was around 48.4 hours, which exceeded the IV half-life of 25.3 hours, taking us to the flip-flop kinetics which happen in this, where the drug absorption is significantly observed slower than its elimination, which causes its persistence and long half-life for long-term duration repetition. And darbepoetin max efficacy was every 2 weeks, and SERA was preferred every 4 weeks. With this baseline about erythropoietin and its genesis, followed by its administration and dose, and the indications where we start, we now look into the second component of this particular talk today, that is the HIF-PH inhibitors, desidustat, before we compare both the entities. So desidustat is an orally bioavailable small molecule with protease hydroxylase inhibitor. It mobilizes iron when and may reduce the need of IV iron. It works better in situations like erythropoietin hyporesponsive states, and the safety of these drugs are similar to ESA. Now, if you look at this particular cartoon here, under normoxic conditions, the prolyl hydroxylate proteins hydroxylates HIF alpha with the help of the binding of von Hippel-Lipid protein binding and ubiquitination. So this basically leads to proteasomal degradation, which also is added upon by the FIH1, which blocks the binding of these surface cofactors to the HIF complex, thereby maintaining and regulating the erythropoietin synthesis. So under hypoxic condition, that is 2B, you will see that because of the lack of oxygenation, this particular protein evades the proteasomal degradation. It gets translocated in the nucleus, where it combines HI1 alpha with beta and the cofactors. And because of the presence of low oxygen, the factor inhibiting HIF alpha is not functional. Hence, there is a downregulation of genes like erythropoietin receptor, VEGF, transferrin, upgrading these genes, leading to complete EPO response. But when it comes to the pharmacological actions of this drug, HIF-PHI inhibitors, you can see that they block this PHD complex, by which they are able to evade this proteasomal degradation. But because it is not an hypoxic situation here, the factor inhibiting HIF alpha is not inhibited. So it is able to cleave the compound, and the binding of the HIF complex to the HRE unit is less bound, but therefore it is able to limit the EPO response. So with this baseline in dialysis patients, we were able to, the dose given was around 100 milligrams thrice weekly post dialysis. And in patients who are non-dialysis dependent patients, the ESA was given as 100 milligrams thrice weekly, or switching from an ESA to this agent, it is 100, 125 or 150 milligrams thrice weekly, depending on the dose of the erythropoietin, or whether you're using darbepoetin or methoxypolyethylene glycone beta. So depending on the conversion, the dose will switch from 103 times to maximum a day can go up to 150 milligrams 3 times a week. That is the maximum maintenance dose for a particular desidostat. So when you look at the first component and the second component, when we compare ESAs with our HIF-PHIs, we understand that ESAs, said that it stimulates the RBC production, whereas the HIF stimulates EPO production through improving the degree and preventing the degradation of the HIF, where it also raises the HB, it reduces the need for RBC transfusion and also improves the quality of life, which almost remains same for both sides. Same if given in equivalent doses, as well as you can decrease the dose as per the need. And the head-to-head clinical trials in HIF-PHI showed that there's no difference between both the groups, which we'll see in the upcoming slides. And the complications, the safety profile remain almost the same, with possibility of axillate hypertension, access thrombosis, and whether it also enhances certain malignancies. So when we compare between EPO versus desidustat, what does the trials to tell us? So when we start with the first trial, the DREAM ND study. So in this non-dialysis patients, phase 3 multi-center open label RCT, where the number of patients were 588, and they were among the hemoglobin group of 7 to 10, where desidustat was given to equal number 1:1 ratio of 261 patients, and 268 patients received darbepoetin alpha. And when we look at the outcomes, the time to achieve the target hemoglobin was comparable between the two groups. The percentage of hemoglobin responders were comparable to darbepoetin. So almost 1.93 plus or minus 1.37, which is almost equivalent, better to compare to darbepoetin alpha of 1.84 rise. With safety profile almost negligible, safety is not related to the investigational product. So they concluded saying that desidustat is non-inferior compared to darbepoetin in the treatment of anemia in patients with CKD who were not on dialysis. At the same time, they also found that there was a reduction of minus 9.41 in the LDL levels, and also a reduction in the hepcidin levels of 19.74 nanograms per ml. So the DREAM non-dialysis anemia parameters almost showed improvement in hemoglobin, serum ferritin transferrin, and the iron improvement comparable, and desidustat was non-inferior to darbepoetin in this study. Same group had done the DREAM D study, in which the total number basically is about 392 patients enrolled. It's a phase 3 multi-center open label RCT, where you're comparing the age of patients between the two groups. One is the desidustat group, N is equal to 184, compared to an eptoin alpha group of 189. And in this dialysis set of patients, where E alpha was used, the time to achieve target hemoglobin was little better, almost comparable to the eptoin, and the percentage of hemoglobin responders was almost superior to the eptoin group. At the same time, there was definitive reduction in the LDL levels of minus 8.7, which was significant, and none of these serious side effects was noted among both the groups, and they were only related to the investigational product. So desidustat was concurred as non-inferior compared to eptoin in the treatment of anemia patients which were on dialysis. So the DREAM D anemia parameters also showed an increase in hemoglobin levels, which were comparable, as well as the increase in the transferrin as well as the ferritin levels. So the adverse events were not significant, and also it was related to the group with 7 deaths in the epoine alpha and 6 deaths in the treatment group, but they were not related to the study treatment. Same way, the cardiac outcomes also did not vary much, with some incidents of ACS as well as unstable angina and a couple of incidents of atrial fibrillation. But definitely the DREAM non-dialysis study showed a benefit in reduction of the levels of hepcidin, which was non-significant when it came to the population of dialysis population. So probably the positive effect was the reduction of hepcidin and as well as the decrease in the LDL levels. So summary of these both trials was that it was found non-inferior in increasing hemoglobin in both DREAM-D as well as ND study, maintaining a target range of 10 to 12. There was significantly high increase in hemoglobin with desidustat compared to the baseline values, and the reduction in ferritin, hepcidin, TSAT, and total cholesterol was seen in both the clinical trials. So when you come to another aspect where they try to value each and every component of this particular group of drugs, they found that the effectiveness to decrease hepcidin was most with daprodustat, as well as desidustat exhibited the strongest hemoglobin increasing ability. There was a study from the Department of Savilita Institute of Medical Technical Sciences, Tamil Nadu, where they were looking into the balancing efficacy, health status, and cost effectiveness, comparing desidustat and erythropoietin in chronic kidney disease patients who are on dialysis. So it was a prospective single-center open-label study. It was conducted for a period of 1 year. The participants were basically having an age group between 18 to 17, and they were maintained on hemodialysis for at least 3 months. In the past, with maintained saturation iron levels, no deficiencies were found in folate and B12. The 60 CKD patients were randomized into 2 groups. One was desidustat 100 milligrams 3 times a week, and the second group was getting erythropoietin alpha subcutaneous injections for 12 weeks. And the markers like TSAT, ferritin, hepcidin were as well as baseline health status, and the cost were monitored over 4, 8, and 12 weeks. The comparison of the increase in hemoglobin levels between the both groups were not varying significantly, so almost comparable. And the comparison of hepcidin levels was found to have a significant reduction in the desidustat group compared to the erythropoietin group. Also, they didn't find much difference in the cost between the both teams of desidustat as well as erythropoietin. Indian data based on desidustat, whether it is comparable to erythropoietin in efficacy, there are a lot of single center studies. So the first study is Dr. Dinesh Kuller's team. This study was showing a total patients of 64 numbers. The 33 patients were on regular hemodialysis. 1 patient was on peritoneal dialysis and 30 patients were pre-dialysis. And the common causes were diabetic kidney disease, chronic glomerulonephritis, and basically they had 2 groups. So first group was erythropoietin switched group. So they had 43 patients who were previously treated with erythropoietin, now switched to desidustat. And they had erythropoietin naive group, where 21 patients were EPO naive and started on desidustat without any prior EPO treatment. And they found that the overall improvement was statistically significant in the mean hemoglobin from baseline at the end of 24 weeks. That was comparable with the 2 groups. In the subgroup EPO naive patients and those who were switched from EPO, the rise was almost comparable. And additionally, when comparing the dialysis dependent and non-dialysis patient, the hemoglobin rise was also there comparable in both the groups as well. So both EPO naive as well as EPO switched group as well as dialysis and non-dialysis with similar results. The serum potassium levels were not very high, and they didn't have any patient issues with high potassium levels. And one or odd 5 patients had some minimal side effects which they didn't relate to the directly with the drug, but the vascular stenosis was in 1 patient as well as vascular thrombosis was considered in line with the drug. So this was the mean rise in the patients of non-dialysis versus dialysis, and the EPO mean change in hemoglobin was almost similar. So they concluded saying that the drug is comparable to erythropoietin in both the subsets of patients. When you look at a single center study across another center in Tamil Nadu under the guidance of Sampath Kumar, sir, here what happened is the study had 68 dialysis dependent patients, but they directly received desidustat twice or thrice weekly based on their hemoglobin levels. and safety profile was analyzed. And they found that the significant improvements in hemoglobin levels, pre-treatment of around 7.7 had gone up to 9.94. So they concluded that desidustat is an effective and safe alternative for treating anemia in dialysis-dependent CKD patients, and it can be considered as an alternative to injectable HIF-PHI therapies. The same outcome was also found at Bhatia Rajiv's Institute in Jalandhar in Punjab, where they also concluded saying that desidustat showed a promising outcome in terms of improvement of hemoglobin. Here also they had the same set of patients who were receiving dialysis with good iron backup therapy, and they had given same desidustat 100 milligrams, and the outcome, they didn't have much side effects. They didn't report any thrombosis or vascular events. There was another study from Tarun Jaloka from the 1-year retrospective analysis from a single center. Here also the 100 stable hemodialysis patients were prescribed this drug for a year, and they found that a significant rise in hemoglobin from 9 to almost distinctly 10, 10.5, and the rise in baseline was 17% for patients. For patients at 12 months reached up to 38.9%, showing that non-adherence was observed in 15% because of cost, as well as they were not ready to switch to a new therapy. And side effects, they noted edema in 6%, infection in 5%, and that's noted nothing much in their study as well. And they concluded saying that desidustat is effective in managing anemia in hemodialysis patients in their center as well. Now, in special cases, like desidustat being used in special cases, a patient with severe post-transplant anemia because of parvo B19 infection was treated with this particular drug. So, in March 2023, a 52-year-old man post-transplant received developed anemia. The hemoglobin dropped to 5.8 despite the normal iron and B12 levels. He was a bone marrow aspirate was done, which identified parvo B19. He was started on desidustat 100 milligrams 3 times a week, but initially the improvement was there of hemoglobin to 8.3, but again there was a fall. And here they increased the dose to 150 to 400 milligrams per week. And at that point, they got a very good response, and the hemoglobin climbed up to 11.1 grams to end up with 13 grams. So this is one case. There's another case where erythropoietin-induced pure red cell aplasia was treated with desidustat, and there was a successful management of this patient with a rise in hemoglobin from 6.7 to 4, which was the dip, and then rise to 9 at a dose approximately 400 milligrams per week. Also, there is a new entity about this PhD because of the gene uh, enlightenment. The prolylates inhibitors increase the hemoglobin in autoimmune anemia as well. They found that the RBC lifespan which was decreased because of antibody deposition on RBCs in the presence of desidustat, as you see here in this cartoon. The number of antibodies seen in the vehicle mice is more compared to that in the desidustat. So, and they also found the serum antibody titer significantly controlled or higher in the vehicle rather than in the patient who received desidustat, with the average reduction in the antibody levels. So what does the guidelines say? The KDIGO 2025 guidelines say that you can consider the use of this drug. Theoretical risk in patients who have cancer, polycystic kidney disease, proliferative retinal disease, pulmonary artery hypertension, and pregnancy, where we have to be cautious in because of the presence of theoretical risk. Concerns for risk also presents in patients with cardiovascular events or prior thromboembolic events or prior vascular access thrombosis, hepatic impairment, and seizures. And there is insufficient data to explain the use of this drug in post-transplant kidney anemia as well as in children. The definite use in ESA hyporesponsiveness was also shown in this particular guidelines, where they showed that in patients who have got moderate to severe anemia, not responding and not all the other causes ruled out, can be put on this particular drug. Also, there was the South Asian guidelines developed by one of the major nephrologists of our country, right from AP Abraham Alan Admeda sir to Vivekanand Jha sir. And even they put up this point that this may increase accessibility, particular for non-dialysis patients, because it does not require any hospital visit or self-injection, and refrigeration issues are not there. And in fact, they put up a particular this thing where they showed that how is it different compared to ASA therapy in different set of populations like non-dialysis CKD population, hemodialysis population, peritoneal dialysis population, and kidney transplant population. And they had a clear evidence of ESA hyporesponsiveness in patients and who have got chronic inflammatory states, patients who have got hypersensitivity, patients who have got lower circulating level of erythropoietin, and the efficacy and safety, except for kidney transplant, where we still have more trials to come. Monotherapy versus combined therapy, the last few slides. So erythropoietin along with HIF and PHI is synergistic in action, and hence there can be a sudden rise in hemoglobin and also the dreaded complications which they theoretically explain can be possible. Hence need close monitoring. There are no established trial combining both in a single management. There's always been a comparative trial, but there are some anecdotal reports. Those reports were based on the tried learning curve of HIF PHI. When we were initially trying this drug, they were reluctant to take off the EPOs. At those times, there was a combined effect. But now it is understood that switch over to one another is recommended. So, as per the clinical situation, so monotherapy is quite sufficient. One of the choice as per the patient's clinical situation, we have to incorporate to use whichever we feel is the best for the patient. When we talk about post-renal transplant, there is an upcoming paper where they have seen the efficacy safety of desidostat versus erythropoietin. In this, they had a prospective observational study of 58 renal transplant patients with a hemoglobin of less than 10. 30 patients received desidostat, 28 received erythropoietin. And they were looking in the change in the hemoglobin levels. Both groups showed significant improvement, with desidostat increased to 9.89 from 8.69 and the EPO almost 9.55, starting with 8.54 hemoglobin. So there were no significant differences between the two groups. Safety profile was also not much affected. So desidostat demonstrated comparable efficacy to erythropoietin in improving HB levels. Both treatments had similar safety profiles. So oral administration offers a convenient alternative to EPO injections is what they are considering, but we need more trials to understand the safety of this molecule in transplant patients. So when you look for the current evidence of the pleiotropic effects, we have iron metabolism is improving, glucose metabolism is still in vivo, but trials have shown lipid metabolism and a possibility of decrease in renal fibrosis and inflammation to come in the future. So once benefiting between the HIF stabilizer versus EPO, oral route increases, maintains hemoglobin levels effectively. There is an endogenous EPO production in physiological range. It regulates hepcidin, increases iron absorption, not influenced by inflammation. They both are reversible and transient, no risk of hypertension, lowering of cholesterol levels, avoidance of EPO levels, and avoidance of side effects associated with IV iron. To summarize the whole, current trials show that erythropoietin and HIF-PHF have comparable efficacy in increasing hemoglobin levels. Additionally, decreasing LDL and hepcidin level benefits for desidostat. Combining both EPO and desidostat need close monitoring because of the synergetic actions. But ideally, monotherapy with either of the one is preferable as per the patient's clinical judgment and situation. Thank you.